I'm Alan Rapoport, and I'm working for Neurology Reviews, and we are at the 28th meeting of the Headache Cooperative of New England in Stowe, Vermont, 2018. And I'm with Professor Christopher Gottschalk from Yale, who runs the headache program there. And he gave a wonderful talk yesterday about the acute care of migraine. It was quite scientific and also practical. And I'm going to ask you, Chris, to tell our viewers in just a few minutes, if you can, the high points from your talk as practically as you can.
Fair enough. Thanks again for inviting me, Alan. It was a pleasure talking here and to you. I think the most important take-home message from the talk that I tried to make is that focusing on the outcome of acute treatment of attacks is really what matters. I think we tend to get bogged down in the details of whether one triptan is better than another, and we don't have much information about which NSAID is better, et cetera, et cetera. We have very little prospective information about exactly which combinations of treatments really is better. There's a little bit. So that all says that there's lots of work to do. But the thing we can focus on better is whether or not the treatments that we're giving people are reliably effective. And we have some pretty good tools to do that. So in the American Migraine Prevalence and Prevention Study, Lipton, Buse, and colleagues had looked at this question of asking people at a given time point, how good is your treatment? And if they said, fabulous, a year later, those people were doing really well. And if they said, well, it takes the edge off, which I think we hear all the time, a year later they were not doing as well. There was almost a 4-fold increase in the chance of becoming chronic in just a year. So to me, that is really powerful data that reflects my own experience, that people who have terrific acute control do better. And in my practice, many patients come to me who are chronic migraineurs that have been trying things for years, and they say, oh, those triptans don't work and the treatments don't work. And I say, give me a chance. Let's just go back over this and try the most effective combination of an injectable triptan, a high-dose NSAID, maybe an antiemetic, and see how you do. And most of them come back and say, wow, I didn't think that could happen. I can actually control an attack. And then they tend to get better over time. Then all of a sudden the preventives have a better shot, etc. So just that idea that if we focus on the outcome from the get-go, is it working? I find in practice, and we now have data that correlates with that, that's a really important way to think about what we're doing, what choices we're making. And then it doesn't really matter so much what they're using, it's whether or not it really works. I think, one piece of information that says that we could all be doing a lot better with this is that despite the data showing clearly, for example, that across the board oral triptans provide about a 30% headache response at 2 hours and a 20% headache-free rate, compared to that, injectable sumatriptan is like 55% pain-free. So that's 2 or 3 times as good. So that to me says, well then of course most migraine patients are using the injectable because we know it's better. Well, guess what? 95% of triptan prescriptions in this country are for oral preparations. And I don't think there are other areas of medicine where doctors make that kind of choice. I don't think doctors would say, sure, take oral insulin, it kind of works. We automatically go for the most effective thing we have. So what part of that is fear of needles, and what part of that is not thinking that it's such a big deal, whether you effectively suppress an acute attack, it's good enough if it does something, all of those play into that. So my hope is to kind of shift the focus on, let's do something that works really well and see how much difference it makes, because in my practice, it's a big deal.
And the only thing I would ask about that, and I agree 100%, years ago I realized when the patient comes in to see me and I say, how are you doing? They say, I'm doing great. You can't stop there.
Totally.
And most doctors do, because great may be, I'm 50% better, and it did work in 3 hours, and we don't like that. We like 100% better in an hour, if possible. And 50% better may mean it's going to recur. So I completely agree with you. You got to know how they're doing, but you have to really know specifically how they're doing.
Well, and that, what you just summarized there is what I say to patients all the time, which is I think part of the problem is that these are people who've had this problem so many times for so long that they basically put up with a lot more crap than they should.
Yeah, and if they get 50% better, they're
That's
happy.
better than they've seen, which is
And
a
we
start.
just have to push them a little bit further.
Yeah.
I agree. Well, thanks very much for chatting with us today.
Pleasure. Thanks for having me.